Good evening, everybody. My name is Dr. Matthew Holder, and I am the President-elect of the American Academy of Developmental Medicine and Dentistry, and I am your host tonight for the Physician Education and Developmental Disabilities webinar series, presented in partnership with the Florida Center for Inclusive Communities and sponsored by the United States Department of Health and Human Services, Administration on Intellectual and Developmental Disabilities, and the Florida Developmental Disabilities Council. Tonight is the third installment of our 12-part series. Remember that we will be holding a new installment of this series every Tuesday night at 6 p.m. Eastern Time until October the 9th. Within 1 week of the live event, we'll post the video recording of each of these webinars online at www.aadmd.org. Each of the 12 parts of this series is accredited by the American Academy of Family Physicians for 1.0 credit hours of AAFP prescribed credit. This is recognized by the AMA as equivalent to 1.0 hours of AMA Category 1 credit. At the end of the webinar tonight, we will give you more information about how to obtain your continuing medical education certificate. For those of you who are not physicians, you may also use this link to obtain a certificate of completion. Just keep in mind that we are only able to award continuing medical education credit for this webinar. As always, if you would like to ask a question, please type it in the question box of your control panel. We will try to get through as many questions as possible during the time we have left at the end of the presentation. So tonight we're going to continue our webinar series with a discussion about communication. Since many of our adult patients may not be their own guardian, or they may be poor historians, or they may themselves have difficulty communicating, it is incumbent upon our profession to establish the best lines of communication that can give us the information we need to accurately assess the patient and to render a realistic and implementable treatment plan. Often this means working as part of a team, and that team obviously will consist of you and the patient, but also involves the patient's family and caregivers, as well as the multitude of professionals that will help you care for the patient. So tonight, since we are talking about three different aspects of communication, we have three speakers. Dr. Kurt Stein is a professor and associate chair at the Department of Family Medicine and Rural Health and the director of clinical programs at the Florida State University College of Medicine. In that capacity, Dr. Stein oversees the third and fourth year medical student curriculum at the Florida State University College of Medicine in Tallahassee. He also directs the required clinical skills course for first year students. Prior to moving to Tallahassee in 2002, Dr. Stein spent 3 years in Austin, Texas, as the executive vice president of a not-for-profit educational organization, and 21 years in Denver, Colorado as a faculty member in the Department of Family Medicine at the University of Colorado Health Sciences Center. While in Colorado, he directed a family medicine residency program, was associate director of the Colorado AHAG program, and pre-doctoral education director for the Department of Family Medicine. He is active with the Society of Teachers of Family Medicine, serving on the STFM Board of Directors from 1997 to 2000, and is a member of the Florida Academy of Family Physicians. Preceding him tonight will be Dr. Gene Sherman. Dr. Sherman is an assistant professor at the University of Miami Miller School of Medicine, director of adult programs, and the Len Nursing Director at the university's Mailman Center for Child Development, University Center for Excellence in Developmental Disabilities. She has been a registered nurse for all of her professional career and obtained a doctorate in adult education from FIU in 1997. For more than 20 years, Dr. Sherman has been involved in creating educational and training programs for families and professionals that interact with individuals who have developmental disabilities. She has also conducted more than 150 training workshops and presentations for these same audiences at the local, state, and national levels. Among her many community roles, Dr. Sherman is currently chair of the Family Care Council of Florida, a longtime chair of the Broward County Family Care Council, and is a charter member of the Volunteer Florida's statewide Inclusion Council. Starting us off tonight is Dr. Carol Zangari. Dr. Zangari is a professor of speech-language pathology at Nova Southeastern University, where she provides clinical supervision, teaches at the master's and doctoral level, and directs the Augmentative Communication Education Lab. Her areas of interest are augmentative and alternative communication, assistive technology, literacy for individuals with developmental disability, and online learning. Dr. Zangari presents on topics related to severe communication impairment at the state, national, and international levels, and is a past coordinator of the AAC division of the American Speech Language Hearing Association. She is a co-editor of Practically Speaking, Language Literacy and Academic Development of Students with AAC Needs. Also, Dr. Zangari blogs at www.praacticalaac.info. That's www.practicalaacinfo. And we'll put that link up later on in the presentation. So, with that said, I would like to turn over the presentation to Dr. Zangari.
Good evening, everyone, and thank you for joining us. I really appreciate the opportunity to speak with all of you about improving the communication between people with developmental disabilities and their healthcare providers. I've been asked to speak on these learning objectives, and in this first segment, I'd like to really talk for the majority of my time on strategies and tools that can help the communication process run smoothly. Before we talk about tools and strategies, I want to spend a little bit of time exploring the problem. As we all know, communication is infinitely complex, it's highly nuanced. It's a bit of a dilemma in that it's a basic need, but it requires pretty sophisticated skills. To start with, I'd like to kind of think about your role in the communication process. As a healthcare provider, you have patients, you have a lot to share with them, you want to connect with them, you want to understand them, understand what they're experiencing so that you can provide effective services, efficient services. And in every interaction, you're both the sender and the receiver of messages. And that means that we have to consider the possibility of breakdowns that can occur with either role, either as the sender or as the receiver. First, let's consider the healthcare provider as a communicator. You're constantly sending messages to give information, to explain, to tell about something, to reassure, to maybe ask questions. And the fact that you're doing that with a very diverse population, such as individuals with developmental disabilities, does present some challenges. Some of our patients with developmental disabilities are going to understand everything we say, others almost nothing at all. And so it presents the challenge because to be effective, the message has to be constructed and delivered in a way for the patient to fully understand it. And if there are these limitations in comprehension, and often there are, we have to do some things to prepare for that challenge in their receptive comprehension. So we have this problem of the possibility of receptive language issues, but in addition, there are expressive language issues. People with developmental disability may communicate to us in a wide variety of ways, and some of those are going to be, very familiar with, to us. Others are going to be less familiar to us. Most of these individuals speak, of course, but with a range of intelligibility issues, some highly intelligible, some less so. Others communicate with us in other ways. They may speak with an external voice output device, such as an SGD, a speech generating device, or they might use things like picture communication boards or books. They may sign to us. They may use idiosyncratic gestures or vocalizations and movement. So as we move further down my little list here, the more challenging it can be to understand the communication they are giving back to us. So we have challenges in these two areas, how well they're going to understand us, the receptive language capabilities that they present, and how well they're going to express themselves to us. So if they have little or no deficits in both areas, we don't really need special tools and strategies and methods. But if they do have significant problems in one or perhaps both areas, then the need for supportive communication strategies is going to play a big role in all of our interactions. So once we know what the patient's receptive language is like and how that patient communicates to us, we can figure out what we have to do in order to maximize communication effectiveness. Now, how do we get this information? Well, without putting too fine a point on it, we ask. And depending on what the patient's skills are like, we may also need to ask supportive caregivers. And I know you're going to be hearing a lot more about that tonight. We have to ask in skillful ways, of course, because it's a bit tricky to get accurate answers. So when Mauricio's mom tells me that he understands whatever she says, she may be 100% right. Or she may not be right and fail to realize that a lot of time when she's talking to him, she's doing so in a very predictable setting where there are lots of contextual cues, and she's interpreting his responses as the person who has intimate knowledge of what he likes and what he doesn't like, what his habits are. So it may be that in the morning when he comes to the kitchen and says, you know, go get your cereal bowl and Rice Krispies and take them to the table, and Mauricio does it, that he's not really responding exclusively to her verbal instruction, but rather responding in an expected way, given that he has Rice Krispies in a blue bowl every morning pretty much, and eats it at the kitchen table. So getting accurate information about how much they understand can be a little bit tricky. One strategy that works for some healthcare providers is to use questionnaires and checklists to get this information in advance, and many of you may already do that on your intake forms. Another thing that I want to share with those of you who aren't already familiar with it is a tool called the Communication Passport. A Communication Passport is essentially a guide to communicating with a particular patient. It's very individualized, and it's something that you could send to the patient in advance and have somebody fill that out, so when they come to you for whatever visit and procedure they're having, you can have an idea of what their particular comprehension and expressive capabilities are. So in this slide here, I've given you a couple of examples of different communication passports. You can see that there are many different formats, some more involved, some less so, some commercially available, and some rather homegrown. They tend to cover pretty basic things, like how you should communicate with the patient, how he or she might express pain to you, and things like that. In a couple of days, we'll have a resource list up for you on the PEDD site, and one of the things that I'll have on that resource list are some free downloads if you're interested in getting something like this for your particular practice. So something like a communication passport gives us information about this particular patient's communications abilities and his needs. What else should we be thinking about? Well, in general terms, here are some do's and don'ts for people with limited comprehension. As often as you can, speak directly to the patient. For the most part, you're going to speak normally, treating them like adults, of course, and if they're using some kind of alternative communication system, you want to try and respect and use that as much as possible. It helps if you can supplement your responses, their responses that they're making on those systems with your own observations. You need to watch for signs of confusion or comprehension so that you can provide clarification whenever it's needed. It's also helpful to make language visible, and we'll talk a little bit more about what that means in a minute. But basically, you want to use gestures and pictures and objects in the room to support what you're saying. It's very helpful if you can be redundant and say the same thing in more than one way. This kind of planned redundancy is a really effective strategy, but you do want to be a little bit careful about saying too much at once. It's helpful to limit the amount of information that you're sharing at any one time. So a couple of things to avoid. The first is speaking to caregivers instead of the patient. There's sometimes when you have to do that, but I always think it's a good idea that if you have to do that, you want to ask permission first. So I might say, Jenny, I want to talk to your mom about your headaches. Is it okay if I tell her how this medication works? And then I can proceed. Try not to speak louder or to use an exaggerated term. And I would really suggest against using the term mental retardation. It's viewed pejoratively by some, and there's a big movement, as a matter of fact, to stamp out that the R word, as they say, and really no sense in offending somebody unnecessarily. Of course, you want to avoid medical language or jargon as much as you can and use plain speak. And finally, try as much as you can not to ask directly if the person understands. When we ask, do you understand, people are almost always going to say yes, whether they do or not. It's probably better to ask an open-ended questions, and it could be specific to a particular topic, right? Like what you could say, like, what should you do before you take your pill, or what do you have to do to your puffer before you use it? Or it could be something general, like, what kinds of questions do you have for me? All right, so let's talk strategies. I mentioned earlier about the strategy of making language visible. When somebody has a comprehension problem, it's really a good idea to try and be redundant in the visual realm. So another thing you can do is to make language visible using pictures, objects, and gestures. You can use what you've got in the room, like brochures or posters or equipment, to supplement what you're saying, but you can also use special communication boards like the examples I'm showing here. This is something that is recommended for a broader population of communication vulnerable people, like folks with dementia or hearing loss or limited English proficiency. Its use is really not limited to folks with developmental disability. But you see some examples here, both commercially available ones and ones that hospitals and practices have created on their own. And again, I'll include links to some of those in the resource sheet that we're assembling. More strategies. This one is really especially helpful to people with autism spectrum disorders. Visual schedules. Visual schedules are really helpful for people who are anxious because they lack a good understanding of what's going to be happening. Essentially, visual schedules are a visual representation of what's coming up. It might be the steps to a procedure that's going to be done. It might be the parts to an office visit. And usually they have pictures in print, but sometimes just print if the person is literate. It's best to have them in advance and prepared, but sometimes we also make them right on the spot. So the idea is this: it really helps to know what to expect. So events that are familiar and predictable to us may seem very random to the patients who are coming to your office or to your clinic. And randomness is not good for the nerves, but predictability is. It's very calming, and knowing what's going to happen really helps decrease anxiety. And of course, that's true for all of us. If you came tonight and instead of listening, you were asked to speak to the group for 15 minutes, your anxiety would increase, not because you couldn't do it, just because you weren't mentally prepared. So how could you use a visual schedule in the kinds of work that you do? Well, you could have your staff make some simple schedule that show the parts of the routine procedures you do or the routine visits that folks have. And what you'd want to do is go over it with the patient at the start of the process and then keep referring to it as you go on to the next step. In a best case scenario, you want to check off or cover up the steps as you complete them so that they know that the next one showing is the next one you're going to do. So these are strategies that many of your patients use effectively in settings, in other settings with really good results. And you can get the family involved as well. You can have them make these kinds of things for the patient and bring it with them to the visit. It's a pretty simple strategy, but it is one with a good research base that yields, pretty good results. For folks with significant autism and limited comprehension, it's a standard of care in most educational settings. So a lot of folks will already be familiar with it. First then is a similar concept. You're going to show them what they have to do first and then what will follow. And again, it really helps to ease anxiety and make transitions easier. The way that we do this is usually it's the less preferred thing that goes in the first column and the more preferred thing following that, right? Same principle we all use. First I go to work, then I get my paycheck. So it can be very helpful for people who are anxious and have challenging behaviors, and of course some people with developmental disability do. Right, so I might say first I'm going to check your body, and then you can play with your Game Boy or read a magazine or listen to music or whatever calming thing works for that individual. So for these folks, knowing that the less desired thing isn't going to last forever and that something pleasant is going to follow it may be just the thing that helps them cope without having a meltdown. And again, it's a really good strategy for people with autism spectrum disorders. But let's go back to more general strategies. Some general things we can do to help if comprehension is limited. One is slow down. Speaking a little bit more slowly gives them some additional processing time, and that's almost always a good thing. We talked before about using simple sentences and vocabulary, and that's something I want to reiterate. Another thing is to try and say the same thing in different ways, trying to be redundant, rephrasing it in a couple of different ways, but trying again not to give too much new information at once. Another powerful strategy that you're already probably quite familiar with is the show me or the teach back strategy. It's very effective to use after you've taught someone something to do so that you can check their comprehension. So how might you use this? Well, you might have them show you how to apply a topical lotion or how to use an inhaler after you've shown them what to do. Or maybe you're having a conversation about diet and nutrition and you're talking about portion size. You can have them show you how big a serving size might be for a particular food. So having them teach you back or having them show you is a good way to check for comprehension. It gives you a lot of insight as to what they took away from your instructions. So remember, when you ask the question, do you understand, or did you understand what I said, people usually say yes, whether or not they really did. You're going to get a false positive fairly often. But using these visual supports to supplement what you say, using some of the other strategies and the teach back strategy may help with that particular situation. Again, we'll have some resources for some of this on the website for you in a couple of days. So my hope for my portion of the presentation was to give you some ideas for making communication run a little bit more smoothly when you and your staff are interacting with people who have expressive and receptive problems secondary to developmental disability. Does it take more time and effort? Yeah, a bit of both. But this clinical population includes a group of people with known communication challenges, and those folks are 3 times more likely than others to experience preventable problems. So in the end, if a little more time and effort prevents an adverse effect, it may be well worth the effort. So I'd like to thank you for your time and attention. At this point, I'm going to turn the discussion over to Jean Sherman, who will be continuing for us.
All right, thank you, Carol. I'm going to turn this over to Jean. Dr. Sherman, are you with us?
I am indeed.
All right, thank you. I think we just need to see your screen if you can pull it up. Perfect. Oh, we just lost it.
No, there it goes.
There we are. Okay, thank you very much.
All right. Good evening, everyone. You're going to hear me make a couple of comparisons probably to some of what Dr. Zangari shared with you. But I think the first thing I'd like to tell you is that you will often see individuals with developmental disabilities appear in your office setting accompanied by a caregiver who may be related to them if they live at home. It may be a family member, usually a parent or a sibling. If they live out of the family home, they're likely to be accompanied by a staff person, a direct care staff from the group home, for instance. And yet there's a third category, of course, of people with developmental disabilities who come solo, alone, to their own appointments. So everything that you've heard from Carol will pertain to how you speak with and communicate with a person with a developmental disability. But when I talk now about the caregiver, there may be some issues here that you are going to need to include with that person who is there by themselves in your office, just as you would with any other patient. But in considering the learning objectives that we're going to cover in this portion, we really want to look at who the patient support network is, appreciate the need, perhaps more than with any other type of patient, to review their written health record, and find out whether the accompanying person really is the primary caregiver, the person who knows this individual best. Because sometimes, sad to say, if it is someone from the group home, it may be whoever is available and not the person who really deals with John on a daily basis. So you have to make that distinction in order to be sure you're communicating appropriately. And I think one thing we can also look at is how important the caregiver might be as a health advocate for this individual, both during the time they are with you and also the time when the person is back in the community, to make sure that they are complying with medical treatment and to be an advocate with the pharmacist, with any auxiliary health professionals that they may come in contact with. And finally, of course, listening is going to be important for you with the caregiver. So the first thing that I'd like to emphasize is, once again, ahead of time, it would be the best to request that the record for this particular patient is sent to you. And the reason I say that is experience has taught that not always will that caregiver from the group home, for instance, show up with a full health record, and you are left wondering what the history of this person may be. So When you know ahead of time, it's best to have your office request that the record be sent before the appointment so you'll be sure you have that information there. And I guess the caveat that we like to impart with all health professionals with whom we work is that it's important to remember that this person's disability is not an illness, and that certainly is not the reason that they are presenting with you today. They're coming either with a symptom, for an illness, for a checkup, but not because of their disability. That just happens to be a coincidental part of who they are. If they have not sent the record, it's important that they bring it with them, and the caregiver has that to provide you with some background information. But you want to know about any existing medical conditions, allergies, and current treatment regimen, as well as past, what has worked before, what hasn't worked. And, of course, looking for those potential medication interactions and polypharmacies. With people who have complex medical conditions, this becomes quite an issue, and many of individuals with developmental disabilities will have coincidental conditions beyond their developmental disability. So when you're interviewing the caregiver, it's important to keep both together in the room. As Dr. Zangari mentioned, you don't want to really be speaking with the caregiver apart from the patient unless the situation really necessitates that and you have received permission. But it's important that everyone is hearing the same thing in order to keep compliance at the highest level. Again, not hurrying the visit. There are time-based codes that you can use for your billing, for your records, and I know there's another session that's going to be part of this webinar series that will get into that in more detail. But this is always a question that practitioners will ask. Well, if we need to spend more time, how are we going to be sure that we're being paid for it? So I know that's something that will come up in the future. Again, I say avoiding medical jargon because oftentimes the direct care worker who will be there in lieu of the family, they do not have any real medical expertise, and so speaking with them, you need to speak in simple terminology and speak clearly as well. Perhaps more importantly is giving this caregiver written instructions, whether it is a parent or whether it is a paraprofessional that works with this individual. They need to have it in writing. And have this caregiver repeat, as in the teach back, have them repeat in their own words what indeed you have told them to do before they leave today. Certainly they need to ask you questions. Oftentimes the caregiver, when it is a paraprofessional, is not given that opportunity, and they return back to the group home with not the sufficient amount of information they need to comply with your instructions. So make sure you allow them time to ask you questions about what you expect in this particular patient's environment, whether it be the family home or group home. There is a difference in how things may be able to be implemented. Importantly, establishing eye contact with the patient and caregiver communicates a level of confidence in you that they may not otherwise have. And a simple way to gain confidence is shaking hands with that caregiver at the beginning and end of the visit, because that establishes your respect for them and their importance in this particular interview. And regardless of their communication ability, it's really the case that you should presume that this particular patient is competent to understand you, unless there is an issue where the legal guardian has presented and identified him or herself. But too often we find medical professionals really will consider when there is someone accompanying the patient, the caregiver is the person they should be speaking to. And that really does not lend itself to compliance and certainly the dignity or respect that that patient deserves. So speak to, encourage the patient to answer, and then allow the caregiver to clarify the answer if not needed for you to understand. or if that particular patient does not answer. But they should never be the one answering for the patient. And that's an easy habit to fall into, and so we do stress that. Now, if this caregiver indeed is the person who knows the individual patient best, then they're going to be able to give you a history and talk about their daily routine, talk about how you may be able to implement your instructions for this person, and they'll truly be able to act as the bridge between you and other healthcare providers and truly be a collaborator in this whole encounter. They will be actively involved in assuring adherence to the treatment plan, or will be passing along those instructions to the person who is the primary caregiver. Often in a group home with shifts of staff, you will have someone in the daytime passing along information to someone in the nighttime or on weekends. So it is important that all of these caregivers are understanding the same thing, hence the need for written communication and for you to be clear that they are understanding you before they leave your office. All of this health advocate's role will be to also to help maintain that particular patient's health record and keep it up to date between visits. So just some general communication tips here. You've heard about the need to treat the patient with respect. Well, the same goes with the caregiver. And it's an important atmosphere that you can create by how you and your office staff really treat this duo. And it will instill the need to really comply with your directions in both of them. A suggestion that we often make is that when possible, you schedule the person with a developmental disability for the first morning appointment, because waiting in a crowded waiting room or for an extended period of time does not help if the person has any behavioral issues or simply cannot sit still for that long, and it's going to make things difficult both for the caregiver when they finally do get into the examining room. So I think you would be best served if your staff can see that they get the first appointment in the morning. It's important to listen effectively not only to what's being said but what is not being said, because that may give you clues about the literacy level of the caregiver and their true understanding of your treatment and your directions. For perhaps no other patient is it going to be as important that treatment, referral, and follow-up is done carefully. Too often, when a primary caregiver is present with that patient, follow-up is not done as carefully as it should. So your staff should be the ones who are following up to see that any examinations, any studies, any tests that you are prescribing for that particular patient really indeed be held, and that might require some extra calls to see that's been done. I mentioned the long waits in the waiting or exam rooms both. Sometimes it's one wait in the waiting room, and as we all know, there can be a wait in the exam room. To minimize those would be the wisest choice for all, because you're going to find a caregiver who will be able to listen to you when the patient is really more settled and can be ready to communicate. Allow enough time for the visit, get all the information, and when possible, it really is useful for you and your staff to become familiar with the community resources that you may want to talk to this person about. And there are specific disability resources, and it can coincide very nicely with some of your recommendations for that patient. For instance, if you are suggesting exercise and healthy diet, there are definitely programs going on in the community that these folks can participate in that are primarily or will accept folks with disabilities, and it's always helpful for you to know that. All right, that is the end of my discussion, and I'm going to turn things over now to Dr. Stein.
All right, thank you, Jean. Thanks so much. Kurt, I'm going to turn the presentation over to you so we can see your screen. Can you hear me?
I can.
All right, wonderful. All right, we can see your screen now. Thanks so much.
Good evening, everyone. I've been asked to address issues of professional communication in the care of the developmentally disabled. There will be two specific objectives that I'll address this evening. Hopefully by the end of the session, you'll be better able to collaborate as a member or leader of a healthcare or interdisciplinary team in the comprehensive care of patients, and be able to more proactively share patient information with health and non-health care professionals involved in providing care or supports while maintaining adherence to HIPAA and the privacy rules therein. Part of the challenge of working with developmentally disabled, and part of the joy, is the ability to work with a team of individuals. Just to clarify, when I use that word, what I mean is a group of people organized to work together to accomplish common purpose or goal. And for the purpose of this presentation, that group of people includes healthcare professionals and service providers, and of course the common purpose or goal is the comprehensive care of the patient with intellectual disability or developmental disability. Determining if that group of people, that team, is a true interdisciplinary team depends on a number of factors. Both multidisciplinary and interdisciplinary teams have members from different disciplines working in a coordinated fashion, but the truly interdisciplinary team has higher levels of coordination and features genuine collaboration and accountability among team members. So, who are the likely members of those teams that are involved in the care of the developmentally disabled? Often there's a family member, a guardian, or a caregiver, frequently a caseworker, an advocate, often who is a RN or an MSW. If the patient is in school, there may be a teacher involved. There may be primary care physicians or specialty physicians involved as members of the team. The usual range of therapists, physical, occupational, speech, and language therapists, maybe a psychologist, some home health or group home support people, and others based on patient needs. The question often rises as to what role the patient may play on teams. Patients can contribute to team outcomes and team success by helping to identify preferences, identifying their concerns, and providing feedback to the team. So if your goal is patient-centered care, I think we all should encourage our patients and their families, their guardians, their caregivers to participate as members of the team. You all have worked with teams that are effective, and you probably have worked with teams that aren't so effective, but these are some of the characteristics of teams that are effective. Generally, there's clear and shared vision, and again here, the vision and purpose of our team of healthcare professionals is the care and support of our patient. There are clear roles and responsibilities of the members on the team, as well as strong team leadership. And since this presentation is about communication, I do want to stress that one of the characteristics of effective teams is the ability to communicate and share information regularly. Again, high levels of coordination and cooperation, that characteristic we call teamwork, the ability to mobilize resources to benefit the patient, and the use as well of performance measures to track success. You probably are familiar with the Tuckman stages of group development, the forming, storming, norming, performing stages. These are a little bit different tasks, but you can see certainly the first 3 or 4 of these tasks of identifying the members, the purpose, the team's leaders, and assignment of goals and responsibilities probably are part of the forming stage. But there certainly is a role as well for communicating with each member of the team, providing feedback to other members of the team, and the whole issue of holding each other accountable for the care given. Again, the whole issue of communication is sharing information about patients, and communication being defined as the process by which that information is exchanged between individuals and organizations. The goal for all teams should be that team members and other stakeholders have access to that information, particularly the information they need to monitor and improve the quality of provided services. You may ask, well, what role you may say, I've heard about HIPAA, and doesn't that put limits on the kinds and quantities of information that we can exchange? And it does. HIPAA is the Health Insurance Portability and Accountability Act, and the privacy rule sets standards that address the whole issue of sharing individuals' health information, which in the HIPAA language is called protected health information, by organizations and individuals. Those groups called covered entities. Those terms appear in the statute, as well as standards for individuals' privacy rights to understand and control how their health information is used. But to understand HIPAA, it is important to understand the terminology. That's why I include those terms, the protected health information and the covered entities. Who are covered entities? Well, health plans, healthcare providers, that's us. I'm certain that most of us listening are healthcare providers, healthcare clearinghouses, business associates of covered entities. So if I have someone involved in medical record transcription or billing, they're my business associate, and they're also covered under HIPAA regulations and standards. What is protected health information? Well, it's information that relates to the individual's mental health or physical health or condition, whether that information be about the past, the present, or the future. It has to do with provision of health care to the individual, information related to that, as well as issues about previous, current, and future payment for provision of healthcare services. HIPAA is really about patient privacy and trying to maintain patient privacy regarding health matters, and it really outlines 2 situations where protected information can be shared. One of those is when the patient authorizes it, and the other is really when the privacy rule permits or requires the sharing of that information. And within those permitted uses and disclosures, you see number 2 has to do with information regarding treatment, payment, and healthcare operations. And that's really the portion of HIPAA that's most important to sharing information among the members of an interdisciplinary team, because it's a permitted use and disclosure to share that information with other members who are involved in the treatment, payment, or the healthcare operations, caring for that patient. Authorization must be obtained for use outside of those permitted disclosures and uses. and authorization must come from the individual. So these are two statements from the HIPAA standards that talk about the authorization and when that must be obtained in order to share information. So in summary, I think it's clear that quality care for patients with developmental disabilities can be best accomplished when teams, whether they be multidisciplinary or interdisciplinary, coordinate, monitor, and evaluate care. Communication is part of the keys to success, one of the keys to success for providing care by a team. And though HIPAA puts limits, it really does not impede team communication. So Matt, I'll put that slide up and turn things back to you, I think.
All right, thank you, Dr. Stein. Okay, Carol and Jean, I'm going to take you live here so that we can answer a few questions. First, everybody, in case you're interested, here are the email addresses of our three presenters tonight, and also the web link that Dr. Zangari is affiliated with. I think first, if you have some questions out to our audience, you can still ask them. But I have a couple, and I'm just going to ask this of the group, and you can just speak up when you hear something you want to answer. I thought this was an interesting question. How much does a person's equivalent mental age impact how you communicate with them?
Not as much as their life experience does.
Interesting. Okay, expand on that. You know, I know that I think I agree with you. I've heard a number of clinicians. You know, we do talk about equivalent mental ages a lot, and they say, "Oh, this person has the equivalent mental age of a 3-year-old or something like that," and then sometimes they may treat the person like a 3-year-old, or maybe they shouldn't. What do you think, Dr. Sherman? How do you go about differentiating?
I will answer this more as a parent at the moment, because I also happen to be a parent of a young man with a developmental disability. And it really begs. Yes?
Sorry, go ahead. We just
yes, are you not hearing me?
Yeah, I am now. We had a mic issue for a second.
Oh,
okay.
Go
ahead.
I'm just going to say, when that question comes up that way, it really begs the question, because every individual with an intellectual disability, and that's who this question refers to, is heterogeneous to the next person who may have the exact same disability and even level of disability. They're different because of their life experiences, of who and what they've been exposed to in the community, and some individuals have been protected overly so by their families, have been isolated from many experiences, and so they're not going to have a frame of reference for what you may want to explain to them. On the other hand, many individuals, and my son is a good example, have been out in the community for their whole lives, and so they have much more of a frame of reference, and often, and I may ask Carol to perhaps back this up, there's often a difference between the level of expressive language and the level of comprehensive language, and what the person understands can be far greater than what they're able to express.
Well, I certainly would agree with the things that Dr. Sherman said. I guess, the answer to the question from my perspective would be that the developmental age that you were given should inform but not dictate. in addition to the things that Dr. Sherman said, our diagnostics aren't that great. For adults with developmental disabilities, you know, depending on who did the evaluation, it may not be entirely accurate in terms of, you know, assigning a particular, let's say, age equivalency score to their capability levels. But even, let's say, if it is accurate, I absolutely agree that the fact that they may have been assigned a mental age of 3 doesn't have anything to do with how they're functioning in the real world. Their adaptive skills and all of their other abilities, the experiences they've had throughout their lifetime will enhance what they're capable of doing. And there certainly can be a difference between their expressive and receptive scores. You know, when I was going to school back in the dark ages, we learned that your receptive score would likely be higher than your expressive score. And for the most part, I would say the trends tend to go that way, but it is somewhat individual, and I think we're learning too a bit more specific to different kinds of disabilities. For example, many individuals with autism will learn the understanding of things through expression. So they can express things before they truly understand them, and it's through that expression that their comprehension develops. So those things can be different, but it's not necessarily the case that the expressive, you know, is higher than the receptive, or vice versa.
All right, wonderful. Thank you. I'll ask another question here. I think this actually might be directed more at Dr. Zangari here, but this question was, how do you think technologies like iPad apps will enhance visual schedules and other things like that?
Well, I'm so happy to get that question. It has changed the game a lot, and one of the things that I put in this handout that that will be available to you are some apps that are free for a variety of communication purposes. And I don't remember if I did include any for visual schedules, because I don't know if there's any free ones, but there certainly are those that are low cost, and it makes it a lot more portable and accessible. And I think that's going to benefit all of us, because, you know, if that's the case, then we're all going to use more of them. However, I will say that in a practical sense, there are still a good number of patients that, you know, I've worked with who still need the tangible, and they still need the physical act of interacting with materials. And so for some things, the old-fashioned paper version may do better for them. But in the larger sense of how technology can help communication, we are absolutely in revolutionary times, and it's just really exciting to be a part of it. So thanks for that question.
I'd like to throw out one comment to everything you said there, Carol, and that is that we have found that the stigma is so much less from a child or a young person who carries around an iPad and uses that for communication purposes than it is for the traditional communication devices that you refer to. And so they much more readily accept the use of this among their peers, and therefore it will promote more interaction in their different age groups than they probably were having before.
Yeah, I think this is something that this emerging technology is, I think, really, as you said, it's revolutionizing the game. I know that I've seen an explosion just in the last couple of years, and I think we're going to continue to see those. And it's amazing what these apps can really do to help people with developmental disabilities. I'm amazed every time I see a new one. Let me ask a question that came from one of our audience members. It's sort of a comment and a question, and it's a good one. But it says, it seems like it takes a lot of time and resources. I think this could probably be directed at all three of you. Is it practical for a general neurologist or a family practitioner to see these patients, or is it better to have a dedicated center? It's kind of a tough question, actually, but I'd like to hear your takes on that, you know, in terms of resources and time, and what the best setting is for delivering care. Don't be shy.
This is This is Kurt Stein, and there are a number of people who just can't access a dedicated center. People living in rural communities and isolated places where it would be extremely difficult for them to travel to a community, to a dedicated center. So in those situations, the local physicians, many of them family physicians, pediatricians, general internists, the primary care docs in the local community, they're going to be called on to see patients with developmental disabilities. So it's just part of the landscape, I think. As far as better or worse, I don't have enough experience with the dedicated centers really to answer what advantages they may have, but I assume that they do have some, but they take the patient far out of their comfort zone in their home generally.
Yeah, I would agree with you there. I think that for the most part, the skills that we're talking about here are learnable skills. When you first start working with this patient population, it's a little different. But just like anything else, you get better at it with time, and it takes less resources and less time the more experience you have doing it. So at first it might seem a little difficult, but oftentimes it does just become rote after a while. And I think that so it may depend on the level of disability that you're working with, perhaps,
Sure.
in terms of how much time and resources it takes. Now, as far as whether a dedicated center is better or not, I would say that, at least in my experience, most of the time, if the private practitioner, can get the right information, then the care should be relatively the same.
Right.
But sometimes sometimes that's harder. In the dedicated center, maybe they have more resources, more expertise, and maybe they have access to a better referral network than a private practitioner, perhaps for some patients. But I think for the most part, the majority of patients, the vast majority of patients with DD, can be seen just as effectively in a private practice setting.
Sure. I mean, you could make the same case, for geriatric patients. They take extra time, or patients who don't have English as a primary language, and where translation is necessary. There are groups of patients in most primary care practices that will take extra time, and that's just, it's common.
Yep, yep. I agree.
I
Let me
think you
ask.
have to make the point that there simply are not enough of the dedicated centers anyway that would ever be able to handle all of
Sure.
the people that need care.
Yeah, that's absolutely right. There simply isn't that, and that's part of the reason why we're even doing this training in the first place. This online training is because if we can, people with intellectual and developmental disabilities represents a relatively small portion of the population, and if we can spread that around to the hundreds of thousands of primary care physicians out there, then that really obviate the need to have a dedicated center. Let me ask a question about nonverbal communication. How important is it when you're communicating with patients with IDD? Anybody want to take that one?
Well, I'll take a stab at it, but I interpret nonverbal communication in two ways. One is the ways that we use our body and voice and proximity to express certain things to patients. But also the bigger field in my area of interest is really folks who don't communicate using typical speech and language. So I guess the answer to the question really depends on the way that the questioner was posing it. Certainly both are important, but in very different ways.
I think the way that this was meant, and this is my reinterpretation of the question that was asked, I think it was meant more in terms of body language and proximity and those kinds of things.
Well, I think it's very important, particularly with people with comprehension problems, because you know, when you're using your body, your tone of voice, proximity, touch, and all of that to supplement what you're saying verbally, it only goes to, you know, support the comprehension of the message. And I think, Jean, were you trying to say something as well?
Only this, that one of the characteristics of adults with intellectual disabilities is that they have been conditioned to agree to things most of their lives, and that if you are asking if someone understood, they're likely to agree and say yes, but their body language may be telling you a different story. And so I think it is important for practitioners to pay attention to what is being said as well as to what is not being said in those instances.
All right, I have a couple more questions here. One for Dr. Stein. How does your team hold the other team members accountable for the team's goals, caregiving, etc., and who decides this?
Well, generally that's the designated team leader, but I think we all, if you recognize your roles and responsibilities, we all hold each other accountable. Groups of people that practice together, we generally share multiple patients. It's not just one or two patients, and there's an accountability with that familiarity as well. So I think I probably practice a lot like many family physicians in that I develop groups of consultants and assistants to help me take care of patients, and those people generally are people that I can relate to and that I have something in common with, and we share common goals and desires for patients, and just you learn who you can work with, who you can't work with, who delivers to your expectations and who won't, and you basically select the people you want to refer patients to and work with. So if you're assembling a team, you'll selectively pick people that you've had effective relationships with in the past.
Okay, great. I have a follow-up question about the iPad apps. This one is, are there grants available for the iPad apps for families who cannot afford them?
I'll take a stab at this one. Funding is really an issue with the iPad versus dedicated devices. The more traditional AAC devices, which are infinitely more expensive, are, you know, because of our history with them and funding agencies, easier to get funding for through public and private health insurance. The iPads, not so much, although I'm sure things will, you know, eventually sort out and we get this problem solved. But in terms of grants, there are a number of organizations who make it their mission to provide support for iPads and apps for families of individuals with special needs who can't afford them. It's not something I had put on the resource list, but if you think that would be helpful, I can work on that. If you give me a week, I can add that to our resources.
Okay, wonderful. Thank you.
There is also, may I add another comment there?
Please, go ahead.
Here in the state of Florida, and it goes by different names in every state, but we have a publicly funded entity called the Florida Alliance for Assistive Services and Technology, or FAST, and they have a state website as well as regional work centers where they do make loans of all of the types of devices that you've been hearing about tonight, and that does include from time to time iPads. That, for instance, we have a regional center at the Mailman Center at the University of Miami where I work, and I'm associated with that. And I do know that we make these iPads available on a loaner basis to families so that they may try it. and also to individuals, adults, who may want to see if it's something that's going to be appropriate for them. And as far as the apps that go with it, there are new ones coming out just daily. But really, the cost of an iPad is so reasonable in comparison, as Carol said, to all of the other devices, that you're not going to find a whole lot of sponsoring agencies buying them, but you certainly can get them to use, to try out, and on occasion there will be some made available to families, yes.
We have a FAST regional center here as well, and we've found them very helpful with assistive technology as far as loaning it to people and having them check it out and try it before they try to purchase it.
Two follow-up points about those excellent comments. One is that every state in the nation has a Tech Act project similar to what we have here in Florida for FAST. So if people are listening to the recording or on from other states, you know, there is one in your state as well by federal mandate. And then the second point is that as cheap as the iPad is, tablets are even a little bit cheaper, and a lot more apps are coming out which are appropriate for adults with developmental disabilities.
That's great. Thanks for that discussion. I have two more questions. This next one, actually, I had a little difficulty thinking of an answer, and maybe you'll be able to come up with one. This one is from a nurse who oversees a number of group homes. And she says that a lot of documentation is in writing and it's hard to comprehend, and she wants to implement a better communication and documentation system. So this is probably specific to the group home industry. Do you have any suggestions or for documentation systems and interprofessional communication that you can recommend?
Well, I'll take that for a minute simply because of my nursing background and because I'm familiar a lot with group homes, but sometimes the difficulties are not even with the written language, but the language of the reader. We have many direct care staff for whom English is not their primary language, and so that creates problems. And I think it really does point to the fact that we must use clear written directions and try to make a good assessment of the literacy of the caregivers, because when you use very much medicalese in giving directions and instructions for care, it's going to be lost upon these staff, and that was the part of the point I was trying to make in my brief presentation there, that it's different from family members who may be able to go to other resources. Often the group homes have to depend upon the nurses who are only there at certain times, and if the instructions are not clear, then the care is not going to be carried out appropriately. So it really is incumbent upon the providers to use simple and clear language, but there is no getting around the need for written documentation, because it must be passed along from staff to staff at different times of the day and different days of the week.
I would say that in some respects this is another area where assistive technology has something to offer us, and obviously this kind of thing can't be done for all sorts of documentation for protected health information, but let's say you were just trying to convey how to do a certain thing, you know, set somebody up in their wheelchair, or you know, administer, I don't know, put on a BiPAP or something like that. We certainly could use, you know, assistive technology to help explain this better to folks with, you know, literacy issues or language issues. You know, there are smart pens, for example, where you can take notes and then also record the voice of what's going on. And so if somebody, you know, is unable to read a particular thing, they can point the pen there and listen to what was being said as that was being written. So I think, you know, obviously it won't work for all kinds of things, but if I think it will work at least for some.
Okay. One more question here. This is about HIPAA. It's a kind of a comment in the question. The comment is, HIPAA seems like it's always getting in the way of sharing information. So can we share information about the patient with anybody who is on our healthcare team? And if so, how do we officialize who is on our team?
Well, that's a real practical point. I think think generally those that are involved in the care of that patient are, coming together as a team is not generally a formality, but everyone knows who's involved because you get reports from them and you exchange information that way. So that's how I often find out who the members of the team are, because more often than not, even though an interdisciplinary team is the ideal, the kinds of teams I'm involved in are still quite multidisciplinary, where people work in parallel rather than in an integrated fashion. But I don't really know if there's a clear answer to that, except that if you're genuinely convinced that people are involved with the treatment portion of care, that information can be shared. And if you have a question, then it should have a patient authorization to share.
Okay. Yeah, that's always
That's the
always
fallback.
that's your biggest safety measure right there. Dr. Stein, could you put up the last slide for me, please,
Sure can.
on the CME credit? So I would like to thank you all for attending tonight's installment of the PEDD webinar series, and especially like to thank Dr. Zangari, Dr. Sherman, and Dr. Stein for sharing their expertise with us. Thank you very much. If you would like to get CME credit for this presentation, just follow the instructions here on the slide. Go to bit.ly.com/PEDD2012. Just sign in and register. And when you register, you will receive another email, a confirmation email. Check your spam folder to make sure that it didn't end up there, because sometimes that happens. If there are any issues, just go to www.aadmd.org and hit the contact button and send us an email, and we'll try to work with you to fix any issues that pop up. In order to get your CME certificate, you do need to go to the website, and then you will need to complete a survey, and then you'll need to complete the quiz. It's a 10-question quiz, and 7 out of 10 is passing. Once you get the quiz, or once you get a passing score on the quiz, the certificate will be displayed and emailed to you automatically. So again, if you have any questions or concerns, you can email me directly at mattholder@aadmd.org, or also at the contact button there on the screen. Please join us next week, next Tuesday at 6 p.m. Eastern, when we will be discussing the topics of self-determination and consent. I hope you will join us then. And from all of us at the ADMD, thank you very much, and have a good night.